Hello everyone, welcome to Vulvovaginal cyst TOG article live session. Hello, good evening. So good to have you once again. As usual, on Saturday, 4 p.m., we are here for the live, YouTube live, and I welcome you all once again. And thank you for being so regular that you keep on joining every Saturday. And that's a very a motivating thing for me as well. So today we are going to talk about one of the RCOG favorite topic, vulvovaginal cysts. This is a very important topic. A vulva has always been an all-time favorite of RCOG. And particularly if I look into this particular topic, this has already appeared many times in the questions of part 2 and in some of the other form in part 3 as well. But this can be a complete station next time also. So we are going to talk what are the various differential diagnosis and the management options for this. And I will keep tab of our 70% less study time. And as promised, we are going to finish this session in next 20 minutes, right? Because we have stick to less than 70% time, we are going to finish the talk article. So here we go about vulvovaginal cyst. When I talk about the vulvovaginal cyst, they basically whatever structures are there in the vulva. So you have a superficial vulva, then there is an anterior compartment and the posterior compartment. So all of this come into the differential diagnosis for the vulvovaginal cyst. The most important thing is we need to realize what is the what is the right anatomical location, which will give us a keyword for the correct diagnosis and the appropriate management plan. So here we go. And let's start with the anatomy. This is particularly important for the part 1 students. So this is the foundation of the cyst classification. Know the spaces well. So the key anatomical points, that is, if you look at the urogenital triangle, you are looking at then it is the complete space is a diamond shaped structure, but if you divide it in the midline, the anterior triangle becomes the urogenital triangle. So anterior half is the urogenital and the ceiling is formed by the levator ani muscles. Superficial pouch contains the clitoris, bulbovestibule, and the Bartholin gland. Important to know because any of these structures can be the cause of vulvovaginal cyst. Clinical pearl infection spread. This is very important point. Why we are so much worried about it? Because the superficial pouch infection. Yes, take this point very carefully. This is a very important exam point. Superficial pouch infection can track up to the anterior abdominal wall because the Colles fascia and the Scarpa's fascia, they communicate, but it cannot go into the thighs or the ischioanal fossa. Deep pouch infection can reach the ischioanal fossa and the extraperitoneal space as well. And that is here lies the significance of these structures. Something about the embryology, again important for both part 1 and part 2 candidates. The origins of the vulvovaginal cyst. Mullerian duct, that can be one of the reasons. So benign Mullerian cyst, upper 2/3 of the vagina. Now, here it is important to see that the location will guide you from where it is coming. Anterior wall, posterior fornix, cervix, so that can be there here. Now the mesonephric, that is the Gartner's duct cyst, which is actually a remnant cyst, and you can find it in the lateral wall of the vagina. Urogenital sinus, Skene's gland and the Bartholin gland cyst, they can be present. Skene's gland with their location being the paraurethral. It's on both sides of the urethra. Bartholin's comes at 5 and 7 o'clock position. Canal of Nuck, this is a peritoneal cyst. This is cyst of canal of Nuck. This is female hydrocele. Labia majora, mons pubis, 1/3 with the inguinal hernia. So you have to be careful where it is. Now, so depending on this can be the embryonic origin cyst or they can be acquired cyst. Now the acquired cyst can be the epidermal inclusion or the Bartholin cyst. So first important thing, like looking at the location, you can see what embryologically that cyst means. This algorithm, you may find it quite complicated, but this is actually the one guiding algorithm which I've taken directly from the TOG article, as mentioned here also. So this is the most important one. Now let's look at the history points first. So if it is asymptomatic, or what are the other histories you can find here? Pain, pressure, and discomfort. Of course, because it is in the perineal area, so difficulty in sitting and walking is something which we expect. Dyspareunia, interference with the sexual intercourse, urinary symptoms, and rectal symptoms. As always, we will always follow that if compartment anterior or posterior or the middle, anyone is affected, we have to ask about all three, right? So same rule we follow here. So anterior means the urinary complaints, posterior means the rectal complaints, and in between means the vaginal part. So asymptomatic patient can be asymptomatic, patient can have pain, pressure, or discomfort. There could be difficulty sitting or walking. There could be dyspareunia, interference with the sexual intercourse, urinary symptoms, or the rectal symptoms. Now, let's see what we can find in the exam. It could be a small incidental finding on examination. Now, what to do with this? If it is less than 40 years, just simple surveillance, wait and watch. But if it is more than 40 years, it should be more than 40 years here, then you have to go for the excisional biopsy. This is important here. Now, if we look at the pain, pressure, discomfort, and all these three things here, next thing is to classify what compartment, whether it is a superficial, or it is in the anterior compartment, or it is in the posterior compartment, right? Now, if we look at the superficial, what is there superficially? There is labia minora and there is labia majora. So if you look at the labia minora, it does not have hair follicles, right? Or the sebaceous glands, they are not there. So what can occur there? It can be just a simple mucinous cyst, for which we can actually go for surveillance or excision under local anesthesia. That could be one of the possibility here. If we talk about the labia majora, now it has the hair follicles and the sebaceous cyst. So either it could be epidermal inclusion cyst, which has to be followed in the same way, or if it is a cystic structure, soft reducible. These all are keywords which are going to appear in your part 2 exams, right? Soft reducible swelling on labia majora. What is the possibility? That is the cyst of canal of Nack, for which we can use the ultrasound, MRI, and go for the surgical resection. And most importantly, don't forget, we can consult the surgeon as well in this case. Now, if we are looking at between the labia, it can be hyadenoma papilliferum, for which the same surveillance and the excision is required. Now, if I talk about the anterior compartment has the urethra and the surrounding glands. So, if it is the anterior wall, it can be the urethral diverticulum. If we are talking about the inferolateral to urethral meatus on both the sides, you can suspect the Skene's gland duct here. And if you are looking at the anterolateral and the vaginal wall, anterolateral, see, previous to what I talked about is related to urethra. That is, you can have urethral diverticulum or you have two Skene's gland. Urethral diverticulum will be in the center, Skene's glands on bilateral sides, laterally, and if it is more laterally in the vagina, you can suspect it as a Gardner's duct cyst. In the posterior compartment, what can be the possibilities? So in posterior, posterolaterally, that is in the lower one-third, you may find the Bartholin gland cyst, or in the posterior wall, there could be upper rectal tender fluctuant mass, which is basically a simple perineal abscess there. So these are the various things which we can find here. Let's go through all of these one by one for having a better clarification. Okay, so depending on what compartment you are dealing with, accordingly you can put up your differential diagnosis. Now coming to the next slide, where we are going to talk about each and every important cyst, particularly the different ones which have appeared now. So Heredinoma papilliferum, apocrine glands. These are derived from the apocrine glands and basically the labia majora or the perianal region, because that is where the apocrine glands are. They are red, firm, and mobile, and usually they are in the reproductive age group because they are driven by the estrogen. And usually it is only less than 1 centimeter. You can simply excise and send it for the biopsy to confirm. And there is low recurrence. So very benign and the subtle lesions. Epidermal inclusion cyst. This is acquired on the labia majora. Very, very, very important to notice for the part 3 students that you have to ask the history of FGM in these patients. This is a very, very, very important point here, which you cannot miss because that will be a patient safety point. So you have to ask the FGM history in these patients who have these kinds of cysts post-trauma or the episiotomy. Single or the multiple nodules up to 8 centimeter. They can be as huge as 8 centimeter and usually non-tender. This is important. They are non-tender. Observation or excision. But if you are removing anywhere near the clitoris, you have to be very, very careful. Vestibular mucinous cyst present at the vestibule, labia minora or along the heart's line. They are small, smooth, translucent, benign, under asymptomatic. Nothing to be done, just conservative management is okay. Cyst of canal of Nuck, this is female hydrozine, which is present around the upper part of the labia majora or the mons pubis. It is, of course, as the name indicates, this is cyst. So soft smelling, 1 in 3 has inguinal hernia. 3 types, it could be encysted, it could be communicating, and this could be mixed. Surgical resection and ligation of the canal, because we have to treat it like hernia. It is exactly, you can say, as a female hernia. So same kind of thing. Not only just the resection is important, but you have to close the canal as well. Epidermal inclusion says post FGM is a classic part 2 vignette. Link history of FGM episiotomy to labia majora swelling. Very important for part 2 as well as part 3 students. Please do not forget to ask the history of the FGM in these patients. Coming to anterior compartment. Urethral diverticulum, all-time favorite of our COG. Beware of the cystocele mimic. Don't think all anterior compartment swellings as a cystocele. Misdiagnosis here can cause iatrogenic urethrovaginal fistula. So very clearly you need to know urethral diverticulum, it's present in the anterior wall, midline. It can be because of the recurrent paraurethral gland infections or the trauma. 3Ds. Diverticulum has 3Ds, right? D for 3Ds. Dysuria, discharge, and dyspareunia. Dysuria, burning micturition, recurrent UTI, patient presenting with recurrent UTI. Discharge, what is discharge? Yellowish discharge post-void dribbling. And you can see the yellowish discharge from the urethra, not vagina. Dyspareunia, this is basically the pain during sex, which is also a part of it. Gold standard for diagnosis. Very important part 2 question. MRI. MRI is the gold standard for the diagnosis. Otherwise, you can have a transvaginal ultrasound, ureteroscopy, double balloon urethrogram, but you remember MRI for your exams. Management is diverticulectomy or marsupialization if active infection is there. And mind you, for you, the correct answer is refer to urologist. Refer to urosurgeon is the answer because you are not going to perform this surgery. So refer to urogynecologist is the best answer here. Coming to skin gland cyst, it is paraurethral but slightly lateral. The urethral diverticulum is midline, but this is slightly lateral, so inferolateral. Up to 30 paraurethral glands are there. What is the presentation? Can be greater than 2 centimeter, tender, especially when infected. Red, fluctuant on palpation, can present in the newborns. MRI for shape and the urethral communication. Ultrasound is first line, but MRI is for the final confirmation. What we need to do, we can treat it like any abscess. If it is small, like warm compress, Otherwise, we can excise mass superposition, aspiration if needed, but there is a rare possibility of adenocarcinoma, so surveillance is very, very important. So skin glands present at 11 and 1 o'clock position, right? Your clock points towards the 11 and 1, and for Bartholin, it points towards the 5 and 7. Very important clock points here. Now, anterolateral and posterior compartment. So here we are going to talk about three categories. Gartner duct cyst, its the origin is the mesonephric duct, we have already read, and it is present on the lateral wall of the vagina near the cervix. Small fluctuant cyst, so small fluctuant swelling. You can observe, excise or marsupialize, but your care is to be taken if because if it is close to the urethra, you can injure the urethra there. What about the benign Mullerian cyst? Again, the name itself indicates benign, subtle, sleeping, cystic structure. Anterior wall, posterior fornix, and cervix features are small fluctuant symptom, asymptomatic, and just observe. MRI not 100% accurate versus urethral diverticulum. So it is more of a clinical point here. Bartholin cyst, very clearly, we see it day in and day out, right? 5 and 7 o'clock posterior compartment. Unilateral labial swelling, if infected, it can be painful, red, warm. How to treat? First time, Wood's catheter is enough. Remember, not all Bartholins for even the first timers do not need surgery. You can just insert the Wood catheter in that, and that is 80% success rate for the first timers. This is an important part 2 exam question. Mass utilization is required only in the remaining cases or where the recurring cases are there, and recurrence is 10%. Now, more than 40 years plus recurrent, it is important to do the biopsy. This is a red flag. Important point to note. More than 40 years of the age, recurrent cyst, do biopsy because you have to rule out adenocarcinoma. Wood's catheter, do not miss this as a first line management option for the Bartholin cyst. What about the imaging and the malignancy red flags? Imaging modalities, as I said, translabial and perineal ultrasound, solid versus cystic, echogenicity and vascularity, because vascularity is something which is high risk. MRI, gold standard for UD, 83% accuracy in vulval cancer staging. Endoanal ultrasound, particularly for the perineal abscess or the posterior masses, and urethrography or video urodynamics, that is confirm the urethral diverticulum. But again, let me mention you that gold standard for urethral diverticulum is MRI. So forget everything and remember the MRI. What are the red flags? Vulval cancer. 5% of all gynae malignancies, vulval squamous cell carcinoma can be 90% of the vulval cancers. VIN, pre-malignant, HPV, lichen planus, lichen sclerosus, very important. Pigmented plus minus ulcerated, go for the Keys biopsy. Highly differentiated VIN or the highly malignant lesions, depending on the age of the patient, that can be there as well. Bartholin's, if more than 40 plus recurrent, again biopsy is important because carcinoma. See, at every point we are trying to rule out carcinoma in these various categories. Skin gland, rare adenocarcinoma, surveillance if conservative management. MRI is the single most important investigation when diagnosis is unclear. This is very, very important. And all the red flags will require the biopsies to rule out vulval carcinoma. Let's talk about the EMQ practice here. 35-year-old presents with the dysuria, postcoital dribbling, recurrent UTIs, and dyspareunia. On examination, the compression of anterior vaginal wall causes a purulent discharge from urethral meatus. Most likely diagnosis is. So again, as I said, it's all-time favorite for our COG. So 3Ds, you can see the dysuria, dribbling, and dyspareunia. So altogether, what are they leading to? They are leading to urethral diverticulum. Exactly correct. C is the correct answer here, and MRI is the gold standard thing. Coming to the next question. 28-year-old with a history of FGM type 1 presents with slowly enlarging non-tender 4 centimeter clitoral swelling. She has had 3 uncomplicated vaginal deliveries with episiotomy. Most likely diagnosis. What is happening here? We have read which cyst is related to FGM. This is a very important exam point. So need to remember FGM related cyst, epidermal inclusion cyst, long-term complication of FGM or episiotomy, care with hemostasis if excising near clitoris. Again, an important exam point. 45-year-old presents with third episode of painful unilateral swelling at 5 o'clock position in the last 12 months. When we see the 5 o'clock position, exactly what comes to the mind? It is the Bartholin cyst. Each episode has been treated with incision and drainage. The swelling is currently fluctuant and erythematous. Best next step: a biopsy. What are we expecting here? This is a recurrent Bartholin, right? Recurrent Bartholin. It has happened third time. And remember, we talked about more than 40 years of the age. We have to be careful about the biopsy. So do not just treat, but do the biopsy. So biopsy is the most appropriate answer here. And this is basically the Bartholin cyst, Bartholin abscess, which is there. So the most important point to remember here is that you have to go for the biopsy in this case. Coming to the part 3 domain framework. Part 3 domain framework. So we talked about the important points for the part 2. And remember, we have covered our talk article in 20 minutes. So I kept my promise of completing it in 70% less study time. So if you want the reading of the talk articles in the interesting way, then you have to be with the MRCOG courses, because we are the one who make you prepare in 70% less time. So part 3 domain framework, how a vulvovaginal cystation maps to your 4 exam domains. First and foremost, if I talk about patient safety, red flags, identify and asking points in the history and talking about that in the examination, or if it's a structured discussion task, exactly need to tell to the examiner that these are the points I'm going to explore, gives you the distinction marks. So identify red flags, recurrent Bartholin more than 40, suspicious lesion, biopsy. Avoid iatrogenic ureterovaginal fistula, never excite blind near urethra. Refer urogyne colorectal early when uncertain. As I said, if a station is about urethral diverticulum, I'm not the right person to talk about the details of surgery, because it is to be dealt with the urogynecologist. Rule out malignancy. Information gathering. You have to take specific information for all the 3Ds. What is the recurrence pattern? Is this swelling for the first time? Its relation to FGM and the episiotomy is also very important. Then coming to the sitting, walking, discomfort, dyspareunia, urinary rectal examination. Then examine systematically by compartment. If you are in a structured discussion task and you talk about the compartment-wise discrimination, this differentiation, and you talk about the sequence like that, you are good to go. You have structured your task very well. Decide ultrasound or MRI, which one is the good to diagnose. What about the communication? Explain anatomy with the diagrams. Use compartment language. Discuss surgical risk. As I told you, if you are structuring your task by like causes of anterior, causes of posterior, or the middle compartment, that itself gets you a marks for the structured presentation. Discuss the surgical risks like bleeding, fistula, and recurrence. Do not forget the recurrence in this, because that has to be told to the patient beforehand. Address sensitive history sensitively, because you are going to ask about the FGM, you are going to ask about the sexual function. So be very careful about this. Share decision making, observe versus intervene. Applied knowledge, at least exactly pointing out, because patient is going to ask you why this lesion. So embryological thing should be very clear in your mind. Exact diagnosis should be very clear. What are the key pointers, so that you can exactly tell what is the cause behind it. And do not talk the marsupialization is the first line for the Bartholin cyst. It's the wood catheter, which is the first line. Marsupialization is for recurrences. And finally, there is diverticulectomy, which can be done. So in a patient part 3 station, the same patient gives marks across all the 4 domains. Practice switching the gears. You should be able to cover all of them together. So that's how you are going to utilize your this knowledge in the part 3 station, keeping in mind these domain-wise points. So here is the final high yield summary. And before I finish, let me announce that from 22nd, we are starting a part 3 November batch. So if you want to read like this domain-wise, and you want to have a structured examiner sheets, which you can use to practice throughout, and also a written feedback after every presentation, domain-wise, you can start from 26th November for 26th May for the November exam. So new batch starting next week, and we are going to have the orientation as well. So here are the high yield summary points from this particular article. Classify by compartment. First, superficial. What is anterior? What is posterior? So that itself clarifies the reason. Embryology shortcut. Think about the embryological origin. Do not forget that. 3Ds for urethral diverticulum, a very, very, very important topic in RCOG. Favorite, dysuria, discharge, dyspareunia, MRI is gold standard. Bartholin cyst, often repeatedly asked question, first line treatment. Do not forget the Woods catheter. And remember the past success as well. 80% patients have a success. Bartholin, recurrent Bartholin, more than 40 years. Do not forget the biopsy here. Even the skin gland surveillance is also required. Cyst of canal of Nuck, take it as a hernia, right? You have to treat not only the cyst, but also close the sac. Epidermal inclusion cyst, very important point. I'm repeating it again and again. Be careful about the FGM or the episiotomy complication here. And then finally, it is the hyaridoma, that is papilliferum. It is an estrogen-driven reproductive age thing. So do the excisional biopsy and the low recurrences are there and patient will be treated. Now your all questions are welcome. Thank you. Do like, subscribe and comment your doubts and see you in the next live session. And these are our contact details. If you are somebody who is planning your part 3 journey with us, then you are welcome to start right now with us. So yes, your questions are welcome and I will be happy to take your questions with us. Yes. Any questions for me? Yes. So we can have the questions here in the chat box. That's perfect. Okay. So started. No. Yes. Okay. So any questions? Any questions from your side? We can have those questions here. Yes. And do give me the feedback as well. Like, how do you like the session today? And do you find reading the TOG articles this way interested or not? Okay, so any questions? Any questions? Any questions? Hello, hello, yes. Hello, hello. Yeah, so good. So good to have you all here. So any questions regarding this or anything which you want to be clear about, and what next you are looking for the next Saturday? You can tell me that as well. And how many of you attempted the questions actually when we were going forwards with that? Yes. Yeah. So good to have you all around. Thank you so much for joining today. And here we finish our today's live session. And as promised, I have completed this discussion in less than 25 minutes. I'm open for your questions if you have any. We can solve them as well. Okay, so bye-bye. Take care. Have a nice evening ahead. And we'll meet again in the next live session next Saturday, 4 p.m.